I will talk shortly about the venous anatomy of lower limbs. The venous system of lower limbs is composed of superficial venous system, deep venous system, and perforators. Okay, just to remind you of the venous anatomy of lower limbs. The superficial venous system is composed of dorsal venous arch, greater saphenous vein, and lesser saphenous vein. Now, the great saphenous vein, which is very, very important because it's a common site, varicose veins. The great saphenous vein, first, it begins as a continuation of the dorsal venous arch on the dorsum of the foot, as a medial continuation of the dorsal venous arch on the dorsum of foot. And then it ascends anterior to the medial malleolus in the medial aspect of the leg, in the anteromedial aspect of the thigh, and it will terminate into the femoral vein in the groin at the fossa ovalis, just 2.5 cm, 1 inch, about 1 inch below and lateral to the pubic tubercle. This site of joining between the common femoral vein and great saphenous vein is very, very important in varicose veins. Now, what about the short saphenous vein? Also, the short saphenous vein arises from the dorsal venous arch of the foot, but as a lateral continuation, and it ascends lateral to the posterior to the lateral malleolus, and it empties into the popliteal vein after penetrating the fascia and in the popliteal region. Okay, so the site of joining between the great saphenous vein and the common femoral vein is called the saphenofemoral junction. And the site of joining between the short saphenous vein or lesser saphenous vein and the popliteal vein in the popliteal fossa is called the saphenopopliteal junction. Both these junctions are very important to deal with in the treatment of varicose veins. Now, as we see here, the great saphenous vein starts as a medial continuation of the dorsal venous arch, as ascent in the medial aspect of the leg and the anteromedial aspect of the thigh to join the common femoral vein in the groin at the saphenofemoral junction. And the short saphenous vein or the lesser saphenous vein begins as a lateral continuation of the dorsal venous arch, just posterior to the lateral malleolus, and along the medial aspect of the calf to join the popliteal vein in the at the saphenopopliteal junction in the popliteal area or region. Now, what about the deep system? Deep veins. As you know, deep venous system is located below the muscular fascia and serves as a collecting vein and the outflow from the extremities. Most of the venous outflow, about 80%, from the limbs, is through the deep system. The deep veins of the lower extremity consist of axial veins, which follow the course of the major arteries, and the intramuscular veins, as we see here. Axial veins accompany the axial arteries. We have common femoral artery and common femoral vein, superficial femoral artery and superficial femoral vein, deep femoral artery and deep femoral vein, popliteal artery and popliteal vein, and so on. Anterior tibial artery, anterior tibial vein, and so on. These are the deep veins, follow the axial arteries. The deep veins, or the deep venous system in general, accounts for 80 to 90% of the venous return. So the superficial venous system accounts for only 10 to 20% of the venous outflow from the lower limbs. So most of the venous outflow from the lower limbs is through the deep veins. Now, what about perforators? Perforator veins, they connect the superficial venous system to the deep venous system at various points. They travel from the superficial fascia through an opening in the deep fascia to enter the deep veins. They are guarded by valves, so the flow is unidirectional. Okay, the flow normally is unidirectional from the superficial system through the perforators to the deep system, and not the reverse in normal situation. Reversal of flow through the perforators, that to say from the deep to the superficial, will lead to varicose veins. We have many sites, especially in the legs, for perforators. We have lower cockets, middle cockets, and upper cockets. In the middle aspect of the leg, we have the poise perforator just below the knee. We have the dot perforator just above the knee, and in the thigh, we have the Hunterian perforators. Okay, these names are just to remind you. Okay. Now, what about the valves? As you know, the venous valves, they are most prevalent in the distal lower extremity, whereas as one proceeds proximally, the number of valves decreases to the point that in the superior and inferior vena cava, as you know, no valves are present. These valves prevent reverse flow in the veins. They allow unidirectional flow from down upward. They also ensure that the blood is pumped from the superficial to the deep venous system and back towards the heart during walking. So it is unidirectional flow from the limbs to the heart and not the reverse. So they keep what we call the hydrostatic pressure system, which is very, very important for normal venous flow. Any defect in this hydrostatic pressure will lead to what we call venous hypertension, and later on may lead to venous insufficiency and varicose vein, as we will see in a moment. Okay, now venous return from the lower limb is governed by, first, calf muscle pump. The return of blood to the heart from the lower extremity is facilitated by the muscle pump function of the calf, a mechanism whereby the calf muscle functioning as a bellows during exercise compresses the gastrocnemius and soleus sinuses and propels the blood toward the heart. This is called musculovenous pump. This muscle function, what we call musculovenous pump, is responsible for the dynamic pressure, which is also very important in keeping the normal venous outflow from the limbs. So we have hydrostatic pressure, which is kept normal by normal functioning valves, and we have the dynamic pressure, which is kept normal by the calf muscles. Normally, in normal situation, venous pressure inside the deep system during relaxation is about 20 millimeter mercury, and during contraction is about 80 to 100 millimeter mercury. Just keep in your mind hydrostatic pressure and dynamic pressure. Hydrostatic pressure inside the venous system is kept normal by normal functioning valves. Dynamic pressure is kept normal by muscle contraction. Also, venous return from the lower limbs is facilitated by competent valves. The normally functioning valve in the venous system prevent retrograde flow. Also, it is kept by gravity. Also, it's kept by arterial pressure. Okay? And thoracic pump. All these factors affect the venous return from the lower limbs. any problem with venous return will lead to venous hypertension. This venous hypertension is the key point in the pathogenesis of venous disorders in both lower limbs. The most important is the muscle pump, what's called dynamic pressure, and competent valve keeping what's called the hydrostatic pressure. Now, what about varicose veins? By definition, varicose veins are abnormally large superficial veins. They are tortuous, twisted, elongated, or widened, bulging under the skin surface due to a defect in the valve within the veins themselves. So, in order to differentiate varicose veins, which are abnormal veins, from normal veins, especially in thin people, we have to follow this definition: abnormally dilated, tortuous, lengthened, widened, superficial veins with incompetent or with abnormal valves, as you see here. Now, we have many venous terms. Probably many of you will be asked about them. You may hear about spider veins or telangiectasia. By definition, spider veins or telangiectasias, they are small intradermal varicose veins. Intradermal, within the skin, not under the skin. They are within skin. Small intradermal veins, let's say within the skin, about 0.5 to 1 millimeter in size, in diameter. Also, we have reticular veins. They are subcutaneous, not intradermal. They are subcutaneous, dilated veins, larger than spider veins, about 1 to 3 millimeter in size. They enter tributaries of main axial veins. So, reticular veins, spider veins, and they are subcutaneous. You may notice in the photos, they are even different in color. Telangiectasia are mainly yellow or purple. Reticular veins are mainly green in color. Now, and of course, we have the true varicose veins. Any vein larger than 4 millimeter in diameter is called varicose vein. Okay, are you with me?
نعم دكتور.
Oh, okay. Shall we proceed?
نعم دكتور.
Oh, okay. Now, varicose veins. Now, what about the etiology of varicose veins? We have two types of varicose veins: primary varicose veins and secondary varicose veins. The most common in clinical practice you will see is the primary varicose veins, the most common type of varicose veins in the practice. And the etiology of varicose veins is of primary varicose veins. Primary varicose veins are congenital in origin due to either congenital weakness in the venous wall and the smooth muscles in the wall of the veins are congenitally weak, or congenital abscess of the valves. Superficial veins have no valves, or congenital valvular incompetence. So as you see here, primary varicose veins are congenital. The most common type of varicose veins you will see in the practice is primary, is the primary type. Primary varicose veins are congenital in origin. The second type is secondary varicose veins. When I say secondary, that to say there is cause secondary varicose veins is mainly an obstruction to the deep venous system, mainly an obstruction to the deep venous system, either DVT or pelvic tumor, retroperitoneal fibrosis, obstruction of venous return, or pregnancy, or AV fistula, whether acquired or congenital. You may hear about CAB classification of venous disorders in general in lower limbs. We have clinical, anatomical, and pathophysiological classification. This classification is commonly used by venous disorders of the lower limbs. Mainly in the practice, we focus on classification, on clinical classification, what's called C type of classification. Okay, we start grading from C0 up to C6. No visual or palpable signs of venous disorder. C1 arterial veins, C2 varicose veins, C3 edema, C4 pigmentation, skin changes, and the C5 skin changes with healed ulceration, and C6 skin changes with active ulceration. I want you to focus only on the clinical classification, which is very useful in the clinical practice. Now, the pathogenesis of varicose veins. Varicose veins. First, when you look to this diagram, any etiological factor, whether congenital weakness in the muscle of the veins, valvular absence or incompetence, whether DVT or tumor, any etiological factor will lead to enlargement of the vein. As I said, any etiological factor will lead accumulation of blood inside the vein. This will lead to enlargement of the vein. When the vein enlarges, will become incompetence. Now, beside so when the blood accumulates in the superficial venous system, any cause, the segments of the vein will enlarge. This enlargement of the venous segment will cause valvular incompetence, okay, because the leaflets of the valves will abduct, okay, so the vein will enlarge more. When there is valvular incompetence, there will be high hydrostatic pressure. As I said before, the blood will accumulate inside the venous system. Pressure applied by the calf muscle will lead to retrograde through these incompetent valves. All these pressure, the dynamic pressure applied by the muscle, will lead to venous hypertension. Venous hypertension will lead to more valvular incompetence. This will lead to clinical manifestations of varicose veins. I will repeat the pathogenesis of varicose veins. Any cause, whether congenital or secondary, this will lead to enlargement of the vein. Enlargement of the vein will lead to valvular incompetence. incompetence will lead to high hydrostatic pressure. Dynamic pressure applied by the muscle will lead to more blood deep system to the superficial system through the valvular incompetence, to the incompetent perforators. All these will lead to venous hypertension, will lead to clinical manifestations of varicose veins. Now, what about incidence and prevalence of varicose veins? About 15% of males over 18 years old have varicose veins. 30% of women over 18 have varicose veins. It increases with age, being present in more than half of the population by the age of 65. Risk factors. I have to focus here. Are not the causes of varicose veins. From their name, they accelerate, they enhance the development of varicose veins. Varicose veins are mostly congenital. But in order to have varicose veins, congenital disorders in your veins, whether valvular incompetence or valvular absence or weakness of the muscles, you have the congenital predisposition, these risk factors will accelerate, will enhance the development of varicose veins. Not every person will have varicose veins. He has risk factors unless he has congenital predisposition. There are many risk factors like genetics, hereditary. So commonly in practice we see that varicose veins are familial. More than one member of the family has varicose veins. Increasing age, as I said, gender, females are more affected than males. Pregnancy, oral contraceptives, prolonged sitting, prolonged standing, obesity, prior surgery or trauma. Okay. What about the clinical symptoms of varicose veins? Clinical manifestations. Symptoms: pain, leg heaviness, aching or tension in the lower limbs, tenderness along the course of the veins, burning sensation, exercise intolerance, restless legs, paresthesia, night cramps, edema, skin changes, ممكن pruritus and itching. These symptoms will become more at the end of the day. Okay, and also these symptoms will become more in hot weathers. Cycle. What about the clinical signs? Clinical signs of varicose veins. First, we have special tests, and second, we have the complications. We will focus on them in clinical practice in the next few months, inshallah. We have test, Perthes test or modified Perthes, tourniquet test, Schwartz test, and Figan method or Figan test. All these tests, special tests, we will focus on them in the clinical practice. Now, complications of varicose veins. Common and first complication of varicose veins is thrombophlebitis, that to say, thrombosis and inflammation of the varicose veins. This is the most common complication. Black to brown due to hemosiderin from the RBC breakdown, hemosiderin deposition. And eczema or dermatitis, what we call venous eczema. RBCs lead to itching lead to scratching, and then eczema will develop. So thrombophlebitis or superficial thrombophlebitis, pigmentation, eczema or dermatitis. Other complications: sclerosis, lipoarthritis, or lipodermal sclerosis in duration and fibrosis of skin and subcutaneous tissue. Venous ulcer, hemorrhage commonly occur due to high venous pressure. Even if there's a trivial trauma to the superficial vein, they will lead to hemorrhage or bleeding from superficial varicose veins. And Talib's equinovirus, the rare complication due to progressive scarring around the ulcer, lead to permanent deformity. It's very, very rare complication of varicose veins. What about investigations? What investigations we need in a patient with varicose veins? First, ultrasound or duplex ultrasound, the very, very important and very common investigation used in the to investigate a patient with varicose veins. Very informative, very accurate, and cheap and available ultrasound. It will give us very clear information about the size of the vein, the site of incompetent perforators, the site of incompetent valves, the status of the deep system, and the status of the saphenofemoral junction and saphenopopliteal junction. We may need computed CTV, computed or CT scan with venography, or MRI with venography or venography. These tests are rarely used in clinical practice. We send for double ultrasound or duplex, efficient in evaluation of varicose veins. Now, varicose veins. So indication of treatment. First, of course, when patient has symptoms, pain, cramping, itching, skin changes, patient has symptoms, he will seek for treatment. Pain, fatigability, heaviness, or when patient has complications like skin changes and ulcer, Thrombophlebitis, or external bleeding, or seek treatment for varicose veins for cosmetic reason. They don't like the appearance of varicose veins, of course. The patient has symptoms or complications or cosmetic reason. Sorry. Now, what types of treatment are conservative treatment, sclerotherapy, and endovascular techniques? Two types of endovascular techniques: endovenous laser therapy, EVLT, and radiofrequency ablation. Conservative treatment. Mainly we advise conservative patient for to relieve the symptoms, to relieve the pain and cramps. But the conservative measures the varicose veins. Okay, so a patient with when the patient follows the conservative measures, he will not get rid of the varicose veins. Only he may get some comfort from the symptoms. Conservative measures we use, leg elevation, of course, to enhance the venous outflow and reduce symptoms, sitting and standing, no leg crossing. We encourage exercise, especially walking. Weight reduction is important, and compression stocking. I said the conservative measures will not treat the varicose veins permanently. Treat or reduce the symptoms only, like pain and edema. Sclerotherapy. Sclerotherapy, a chemical agent is injected into the veins. This agent will irritate the venous endothelium and produce localized phlebitis and fibrosis, then thus obliterating the lumen of the vein. Many types of sclerosing agent we use in the practice, like hypertonic saline, polydecanol, or sodium tetradecyl sulfate. Nowadays, in our practice, we use foam sclerotherapy, either sodium tetradecyl sulfate or polydecanol. We inject into the superficial veins. Mainly sclerotherapy is used for treating telangiectasia or reticular veins. Sclerotherapy is used for varicose veins less than 4 millimeters in diameter. Any varicose veins which are less than 4 millimeters in diameter can be treated by sclerotherapy. Although nowadays, in clinical practice, even larger veins can be treated with sclerotherapy under special condition. But sclerotherapy is mainly used for smaller veins, that's say telangiectasia and reticular veins. Surgery. Surgical ablation of varicose veins. We have only ambulatory phlebectomy, stab, or what we call stab phlebectomy. That is a avulsion of varicose veins. Avulsion, we induce stab over the course of varicose veins, small stab, and then we use a special phlebectomy hook to just avult the varicose veins. Stab avulsion technique or ambulatory phlebectomy or stab phlebectomy may be used to remove clusters with varicosities greater than 4 millimeters in diameter, with the preservation of the greater and lesser saphenous vein if they are unaffected by valvular incompetence. Okay, so when we use stab phlebectomy or avulsion of vein alone, when we have varicose veins greater than 4 millimeters in diameter, that's not amenable for sclerotherapy, and the great saphenous vein and small saphenous vein are normal. That's to say, saphenous femoral junction and saphenous popliteal junctions are normal, and the great and small saphenous vein are normal. So we don't need to remove the great saphenous vein and short saphenous vein. We need to remove the clusters of veins, because the great saphenous and small saphenous are normal, not involved by valvular incompetence. This is called a stab avulsion technique. Can be used can be done under local anesthesia, as you see here, using special phlebectomy hook. Now, we have a Trendelenburg procedure. Beside stab avulsion or stab phlebectomy, we may need to remove the great saphenous vein and short saphenous vein if they are dilated with valvular incompetence. So when greater or lesser saphenous veins are incompetent, the removal of clusters, that's a stab phlebectomy, is preceded by removal of the saphenous vein, great or small, which is called stripping of great saphenous or small saphenous vein. The Trendelenburg technique or procedure includes high saphenous ligation. We ligate the saphenous femoral junction at the groin. Saphenous stripping, we introduce a device called stripper inside the saphenous vein, and we remove it, and stab phlebectomy, as you see here. Ligation of saphenous femoral junction and the groin. Okay, a stripper is introduced into the great saphenous vein after it is divided from the junction, and the whole vein is stripped out. This is the whole length of great saphenous vein stripped out, and this is the tip of the stripper. Have two surgical procedures, either stab avulsion or stab phlebectomy alone, without removal of great saphenous vein and short saphenous vein if they are normal, or we have stab phlebectomy plus removal or stripping of great saphenous vein or short saphenous vein if they are abnormal. Okay. What about perforators? Of course, when we have incompetent perforators, we have to deal with them. It is not enough to deal with the great saphenous or small saphenous or their tributaries to remove them and keeping the incompetent perforator. Incompetent perforator, you have to deal with it, because if it is left without treatment, the recurrence rate will be very, very, very high. Okay, so if we remove the great saphenous vein or short saphenous vein and the superficial veins without treating the incompetent perforators, varicose veins will recur. Of course. Now, how we deal with the incompetent perforators, either endovenous ablation by radiofrequency ablation or subfacial ligation, endoscopic ligation through an endoscope. We see the incompetent perforator and we ligate it, or by inserting a radiofrequency catheter to obliterate it, or by stab avulsion. Okay, how to deal with the perforator incompetent? By either endovenous ablation or subfacial ligation or stab avulsion. Now, what about endovascular techniques? Just to remind you, the lines of treatment of varicose veins are conservative, surgical, and endovascular techniques. Now, the endovascular techniques, we have two techniques, either endovenous laser therapy, EVLT, or radiofrequency ablation. Of course, whether laser therapy or radiofrequency, a special catheter and the local anesthesia and ultrasound, Doppler ultrasound guidance is introduced in the great saphenous vein or short saphenous vein, either in the upper leg or in the lower thigh, and reaching just below the saphenofemoral junction, and then a laser beam or radiofrequency beam is used to obliterate, by heat effect, to obliterate the lumen of the vein. Very effective technique, can be done under local anesthesia without the need for GA, general anesthesia, and it can be done as a day surgery, and the patient can return to his normal daily work a few hours later on. Now, some photos before and after radiofrequency or laser therapy. And thank you very much. Okay, شباب.
شكرا دكتور.
شكرا دكتور.
I'm ready for any question.
دكتور ممكن سؤال؟
Yes, of course.
الدكتور البرايمري والسكندري
Yes.
البرزنتيشن راح يختلف؟
Regarding the clinical features, they are the same. Okay. Clinical signs also may be the same. Patient ممكن يجينا بعدين راح نحكيها بالمحاضرة الثانية بالفينس insufficiency. Patient يجيك عنده بس varicose veins، ما عنده أي skin changes، زين ممكن يجيك عنده فاريكوز فينز وعنده سكين تشينجز، عنده لايبوديرماتوسكلروسيس، عنده فينس ألسر، عنده discoloration and so on. from clinical point of view they are the same but the etiology is different. اوكي.
العفو دكتور.
نعم تمام.
عندي سؤال ولا موضوعنا الثرومبوسيس.
تمام.
إذا ثرومبس بالبرفوريتنج فين
يس
ممكن يصير سيمتوماتيك تدخل هذا للديب فينز لو
يس ميبي. زين
احنا خطره
اذا البيشنت هنا احنا عندنا لازم نميز اكو عندنا superficial thrombophlebitis يعني ثرومبوسيس بالسوبرفيشال فينز. this is not dangerous. this is not dangerous. زين بس اذا سويت له دوبلر بيشنت وشفت اكو ثرومبس بالبرفوريتر او ثرومبس near by the junction يعني ثرومبس مثلا near by the saphenous femoral او saphenous popliteal junction. This is dangerous. You have to treat the patient as if he has DVT. احسن احنا مريض يجينا عنده varicose veins وعنده ثرومبوسيس بسيجمنت مال الفاريكوز فينز مثلا بالليج بالثاي. زين هذا تعامل وياه ايزلي. اعطينا ستيرويدال بين كيلرز كولد سبونجينج انتيبايوتكس may be needed. اوكي ممكن الفاست ماجوريتي من عندهم ما اعطيهم انتي كواجوليشن ثيرابي. اوكي اتس نوت دينجرس. لكن اذا بالدوبلر الترا ساوند اكو ثرومبس عندي بالبرفوريتر يعني قريبه على الديب سيستم او ثرومبس near the saphenous femoral junction near saphenous popliteal junction يعني again قريبه على الكومن femoral vein قريبه على البوبليتال vein. لا I have to treat this patient as if he has DVT. أعطيه full course مال anticoagulation to avoid DVT. اوكي
شكرا دكتور.
تمام. I'm ready for any question.
دكتور دي في تي شلون ممكن تسوي فاريكوز إذا هي مثلا مرة واحدة وأنا راح أسوي لها تريتمنت؟
تمام very good question. ليش احنا طبعا بالبراكتس هسه احنا نحكيها ان شاء الله بالكلينيكال من تجون صف سادس من نشرح لكم على الفاريكوز فينز. احنا المريض شلون اعرف هذا؟ كل مريض يجيني عنده فاريكوز فينز لازم اساله بالهيستوري عنده دي في تي لو ما عنده دي في تي. طبعا الغالبيه العظمى من المرضى اللي عندهم دي في تي اكيد خاصه الفيميلز راح يقولوا لكم ايه احنا صار عندنا دي في تي صار عندنا خثره. اوكي يسموها جلطه بالرجل. زين فاي مريض يجيني عنده فاريكوز فينز من الهيستوري على مود اعرف هذا برايمري لو سكندري. one and the only one question you have to ask to the patient is about DVT. نقول للبيشنت انت صار عندك مثلا قبل سنه سنتين او اكثر او اقل خثره برجلك يعني رجلك ورمت وصار بها خثره راح يقول لك مثلا اي. زين من مريض يعطيني هيستوري مال دي في تي اوكي وعنده فاريكوز فين ورا الدي في تي صارت فافكر بالسكندري فاريكوز فينز. شلون صارت؟ معناته ما صار عندي كومبليت ريكاناليزيشن اوف ذا ديب فينز. مثلا خلينا ناخذ الكومن فيمورال فين اوكي صار عندي ثرومبس اعطيته تريتمنت انتي كواجوليشن فور 6 months even for 1 year. اوكي طبعا اكو معلومه جدا مهمه اللي تنتبهوا لها. المريض اللي صار عنده دي في تي صار عنده ثرومبس خلينا نقول بالكومن فيمورال فين تمام الانتي كواجوليشن اللي اعطيه وذر هيبارين او جليكسين او وارفرين او زارت او وات ايفر هذا ما راح يشتغل على الثرومبس الموجوده بالفين. بس انتبهوا لان هواي هاي الحقيقه هوايه حتى اطباء ما يعرفوا يعني مو ما يعرفوها بس they are not aware of. صارت بالفين ما راح يشتغل عليها الهيبارين اللي راح انطيه اني او الجليكسين او وات ايفر. اوكي الفايبرينوليتيك سيستم اللي نورمالي موجود in our bodies هو راح يشتغل عليها. الفايبرينوليتيك سيستم هو راح يسوي ثرومبولايسيس بهاي الثرومبوس. it's a matter of time. this fibrinolytic system ايش قد ياخذ وقت على مود يسوي لايسيس بهاي الثرومبوس ما نعرف ممكن اشهر. تمام لكن هذه الانتي كواجولانت ثيرابي اللي انطيها اني just to prevent further thrombosis اوكي، يعني انا شنو يضمن المريض صار عنده دي في تي بالرايت سايد؟ ليش ما يصير بنفس الوقت او بعد فتره بالليفت؟ زين، ليش هاي الثرومبس ممكن تصعد البلمونري ارتريز تسوي بالمونري امبوليزم؟ فعندي انتي كواجوليشن just to protect from further attack of DVT. لكن الثرومبس اللي صارت ما راح يشتغل عليها الفايبرينوليتيك سيستم الموجود بالبودي. ايش قد ياخذ وقت على مود يسوي لها لايسيس؟ some matter of time. تمام. فهسه المريض صار عنده ثرومبس، خلينا نقول بالكومن فيمورال فين وسدت اياه تماما، كومبليت اوبستراكشن اوف كومن فيمورال فين، ليشن، وراقبته ورا شهر، ورا 3 اشهر، ورا 6 اشهر، ورا سنه، كل فتره راقبه كلينيكلي واسوي له دوبلر التراساوند. راح نشوف اكو نسبه معينه من البيشنت راح يصير عندهم كومبليت ريكاناليزيشن، مثل ورا 3 اشهر، ورا 6 اشهر ماكو اي اثر للثرومبس يبقى. فيري جود امبروفمنت، يروح السوالينج، يروح السيمبتومز، يروح كلها. وراديولوجيكلي باي دوبل التراساوند نو تريس فور ذا ثرومبس. ذولا فاريكوز فينز، او اكو برسنتج من ذول اللي البيشنت اللي صار عندهم دي بي تي بالفولو اب اشوف انكمبليت ريكاناليزيشن، مثلا only 25% ريكاناليزيشن or 50% ريكاناليزيشن، وباقي كرونيك ثرومبوسيس بالوول، يعني كرونيك اوبستراكشن، كرونيك ناروينج بالفينز. This will lead to venous stasis، راح نحكيها بالمحاضره الثانيه. venous stasis، venous stagnation below the level of the this stenosis segment or obstructive segment. The venous stasis, reduced venous outflow. This will lead to venous hypertension in the deep system، مثل يعني increase hydrostatic pressure. هذا الفينوس hypertension بالdeep system will be transmitted to the through the perforators to the superficial system valves leading to varicose veins. واضحه؟ بالمحاضره الثانيه راح نحكي عن ديتيلز. يعني من اكو المريض عنده دي في تي، المريض عنده دي في تي اما يصير كومبليت ريكاناليزيشن زين، ويروح له اوبستراكشن تماما وفينوس اوت فلو يرجع طبيعي عنده، فما راح يصير عنده فاريكوز فين سكندري. او لا، يبقى ممكن يبقى الفين عندنا برسنتج من البيشنت اصلا الفين يبقى مسدود فور ايفر. زين، حتى الفايبرينوليتيك سيستم ما يقدر يوخر الثرومبس. المريض صار عنده دي في تي، اما صار عنده ريكومبليت ريكاناليزيشن وفينوس اوت فلو رجع طبيعي، وما راح يصير عنده فينوس هايبرتنشن ديستالي، فما راح يصير عنده فاريكوز فينز، او كومبليت اوبستراكشن او انكومبليت ريكاناليزيشن. فديستال تو ات الفينوس اوت فلو راح يكون ويك، الفينوس ستاجنيشن وفينوس هايبرتنشن. This venous hypertension will be transmitted to the superficial system leading to incompetent valves leading to varicose veins. اوكي، هاي in brief pathogenesis of due to DVT. اعتقد واضحه.
واضحه.
دكتور.
تمام. Any other question?